now at 9 o'clock. Okay. And this is the January 19th meeting of the Behavioral Health Subcommittee of the Incarceration Prevention and Reduction Task Force. This is Dan Hamill. I'm one of the co-chairs. I'm joined today by the other co-chair, Mike Parker, and we do have a quorum this morning. I'd like to have someone other than myself read the land acknowledgement statement. I talk too much during these meetings. Mike Hilly, would you be so kind as to read the land acknowledgement statement?
Yeah, I'd be glad to, Councilmember Hamill. Thanks. So before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that brings us together here today. And please join us in uncovering such truths at any and all public events. Thanks, Dan.
Thanks, Mike. Hey, you know, like I said, we've got some new folks here, and just in the spirit of, you know, reconnecting during this crazy COVID thing that we're all separate with, I'd like to actually go to the screen with all the members on it, Jill, just for a moment here before we get into item 2, and just do some introductions. It's just so I can see everybody here. Let's see. I'm going to call on folks, and if we can just buzz through introductions, maybe just 30 seconds as to who you are and what your role is in the community. Arlene Feld, do you want to start? You're muted, Arlene.
Can you hear me now?
Yeah, you're good now.
Okay. I'm the co-chair of the Legal and Justice Committee, and I attend these meetings because one of my primary interests is the expansion of mental health care in Whatcom County. So these committees have done a great deal of work towards that goal, and I can see it beginning to happen. I think LEAD and Grace are good examples of making tremendous progress. So I'm actually very hopeful and excited. I see important changes in the legislation programs. I see funding coming. And with that, I know that we can do the things that we really need to do.
Great. Thanks, Arlene. Stephen?
My name is Stephen Gockley. I'm a co-chair of the whole task force. I'm also a commissioner for the housing authorities, and I'm on the board of the Whatcom Dispute Resolution Center. This is one of the most active and most central committees on the task force, and I'm glad to be a member of this group as well.
Thanks, Stephen, and good morning. Mike Hilly.
Yeah, good morning, Mike Hilly. I'm the EMS Emergency Medical Services Manager for the county. I manage basically the advanced life support, basic life support contracts that provides your first-rate EMS service out there for both the paramedics and EMTs. And my life intersects with this group through the Fire Chiefs Committee. And in a sort of sideways way, I represent the Fire Chiefs Association for Whatcom County because a lot of these issues intersect with our emergency medical services community. So we feel a great closeness to working with all our partners to advance some of these ideas on diversion and how to better approach our mental health patients, behavioral health issues out there, especially with the crisis stabilization facility coming up. So we enjoy working with the lead group, and actually I took over for Jerry DeBryan. I think he was a representative on the incarceration committee before that. So thank you.
Thank you, Mike. Chris, you want to go ahead?
Sure, I'm Chris Cochran. I'm mental health coordinator for Bellingham Schools. My first time being with you, and I'm excited to be part of it.
Thanks, Chris, and welcome this morning. Mike Parker.
Yeah, thanks, Dan. Mike Parker. I'm honored to be your co-chair of the Behavioral Health Subcommittee. My title is Housing and Healthcare Integration. So everything I do at the Opportunity Council is really working at the nexus of keeping our folks in housing stable with the necessary services. And obviously, if we can divert them from homeless systems, then we've all done ourselves a big favor. So it's great to see you're all here today.
Thanks, Mike. Perry?
Good morning, folks. I'm the Human Services Division Supervisor with the Health Department. I've got a background in substance use disorder treatment and mental health treatment. I'm a proxy member for the Behavioral Health Committee connected to Ann Deacon, and I support many of the current projects that we're involved in that have been referenced before, so glad to be here.
Thanks, Perry. Melora?
Morning, everyone. Melora Christensen. I am the Grace and Lead Program Manager and happy to be here today. Thanks for having me.
Thanks for joining us, Melora. Doug?
Doug Chadwick, I'm the undersheriff here at the Whatcom County Sheriff's Office. And obviously we have a mental health deputy program, and I've been involved with this subcommittee and several others with a similar focus for the last couple of years, trying to figure out how to best get law enforcement and mental health professionals working in conjunction. And obviously we've been plugged in with the GRACE program, and now we're starting with LEAD, and hopefully to divert some of those folks from the criminal justice system prior to arrest.
Thanks, Doug. Heather, if you're able to safely, without crashing your car, you look like you're driving there. Can you join us? Can you just introduce yourself real quick?
Yes, hi, I'm sorry. I'm in the Starbucks drink line. We still need coffee in a pandemic, right? So my name's Heather Flaherty. My day job is being the executive director for the Chuckanutt Health Foundation, but I'm actually here on this committee as a community member. And I'm really grateful to be here, of course. Personally, I really believe in treating things like addiction as public health issues. And I think this committee is a really amazing catalyst and conduit for, have a great day, thank you, for that. So nice to see everybody. Thank you.
Thank you, Heather. Jill?
Good morning. My name is Jill Nixon. I work for the Whatcom County Council Office. I'm the clerk for the Incarceration Prevention and Reduction Task Force.
Thanks, Jill. Jackie?
Can you hear me?
Yeah.
Yeah, okay. I've been having trouble with Zoom this morning. So I'm Jackie Mitchell. I work for the Health Department, Behavioral Health Program Specialist, and I'm also a member of the Legal and Justice Committee.
Okay. Ann Deacon? Hey, Ann, looks like we're having problems hearing you.
Yeah.
Might be the mic on your computer.
I could read her lips. She said she's going to call in.
Okay. Chief Tank.
I just came on the screen, so I don't know where we are at this point.
Just introduction, just who you are and your role in the community.
Oh, thank you. I'm Donnell Tanksley. Most people call me Tank. The chief of police here in Blaine. I've been here since June of 2019. So about 6 more months, it'll be 2 years, and look forward to being a productive member of this committee. Thank you.
Thanks, Chief. Appreciate it. I've got 2 other folks here on the call. I've got 2 Perry Mowrys. I know that you're really smart, Perry, but I don't think you can like split into 2 people. Who is that other person there?
I don't know why it's registering that way other than the invites that I got.
Can you hear me now?
I can see that Ann Deacon is also using my name.
As is Joe Fuller from the health department. And we try to travel incognito whenever possible, but Joe fixed his name. I'm sorry, sometimes my mic just doesn't work. I have to call back in, but I can introduce myself now. I'm Human Services Manager for the county, and our department works in collaboration with our community partners to develop many of the behavioral health programs in place right now, and then we fund them.
Thanks, Ann. Joe?
Morning. I'm Joe Fuller. I'm a program specialist here at the health department. Background really is in prevention work, so part of 4 different prevention coalitions in the county, and also help to convene our Whatcom opioid task force.
Thanks for joining us, Joe. Gentleman in the flannel who looks very familiar with the earbuds, Nathan. Nathan.
Yes, hello. My name is Nathan Baima, and I work at the Public Defender's Office as the behavioral health specialist there. Have a background in probation, parole, also law enforcement, and then in mental health as well, and work a lot really closely with GRACE program right now. And so yeah, I'm glad to be here. This is only like my 3rd time. So
thanks for joining us, Nathan, this morning. It looks like Megan Ballou was able to join us. Megan, do you just want to pop in and just introduce yourself?
Hi, good morning. Sorry I was a little late. Megan Ballou, I'm the Director of Behavioral Health at Lummi Nation. Good to see everybody.
Thanks for joining us today, Megan, and thanks for masking up out there. That's awesome. Okay, Jill, let's go ahead and get the agenda back on the screen. And so we're going to lose a bunch of people here, so sorry about that. I hope folks have had a chance to take a look at this. Jill, can you scroll up to packet page 1 and just show what we're talking about here? Okay, here we go. This is this sequential intercept service delivery summary. And as we know, we've got intercept 0 through 5. And this first page on packet page 1 are things that we're already doing in the community. So I'm not going to go through all, there's so many things that we've been working on for so long. Grace is in there, the homeless outreach team. There's a number of different items, and you'll see those along the sequential intercept. And I'm going to briefly get folks refamiliarized with this. Intercept 0 is community services. Intercept 1 is a law enforcement contact. 2 is initial detention and initial court hearings. 3 is jails and courts. 4 is reentry, and 5 is post-incarceration community support services. And so that is the way that we've been able to kind of categorize and think about these intercepts and diversions on the task force. This is the tool that we use, one of the tools that we use. And Jill, if you can go down to packet page 2, these are items that we have in the community to some degree, and we don't have enough service capacity, resources, or funding. These are things that we've identified as priorities and that we've wanted to work on. Hey, Kelly, can you take that shade down real quick? Sorry, I'm getting blasted by the morning sun here. If you can't tell, it's very intense. And then, thank you. And then, and Jill, if you can scroll down to packet page 3. These are items that we've identified as priorities, but we don't have, but they don't exist in our community for a variety of reasons. And so what I was hoping for today, just, it being the beginning of the year, and we have some fresh faces on the committee, as well as experienced folks who've been doing this for a while. What I was hoping to get to today was to hear back from you all as stakeholders for behavioral health in our community on which priorities this committee should be focusing on this year in 2021. And the purpose of that would be to provide a recommendation or recommendations to the task force, and then the task force could provide recommendations to Whatcom County Council, and then to some extent, the City Council can also be informed of these priorities so we can all be on the same page moving forward. Does that make some semblance of sense to you all? Thumbs up or head nods if so. Okay. All right, folks, I'm gonna stay off of mute here, and I want to leave this screen up on, or leave this packet page 3 up on the screen as sort of a way for us to kind of move forward a little bit in this discussion here, and knowing that we have a number of items here this morning that we need to get through, but I do want to come to some, at least, direction on priority items. And I think maybe we can circle back at our February meeting and confirm some of the items that we've discussed today. So, okay, I'm not able to see everybody. So if you can go ahead and unmute yourself if you want to chime in. and go ahead and speak. And I'll stop talking for a minute here.
Well, Dan, if nobody's going to jump in, I'll real quick. When I heard you speaking, there's a couple of ways I think about this. You can choose a strategy that you really like that we need more of, and we can double down on that. The other way to think about this is there's some problem. Is there some unmet issue that we're seeing? And I guess from that perspective, I think a lot about COVID. We have heard some things, mostly from our partners in law enforcement, and their intel is so valuable. But how has COVID, this extremely long pandemic, which is going to go beyond a year, how is that impacting both this behavioral health population that may or may not be involved in the criminal justice system? So I guess that's one of those things that's just on my head as a pressing need. And that's more of almost I guess a needs assessment or getting some sense of how that's directly impacting people. That would be something I would offer.
I mean, one of the things on my priority list would be the importance of reentry activities. And considering the reports that we've had from the people who were doing reentry programs for us, they were face-to-face type of programs, classes, counseling, and various types of preparation, which obviously I don't see how that could be done now. And the likelihood that people going into reentry are going to have the digital devices that they need to do telehealth counseling or any of the work that they need to do. I don't know. I mean, I have no idea if that's achievable, and but I'm just saying that COVID is, I don't see how we could do this without reworking how we do reentry.
Thanks, Arlene. Hey, Nathan, anything from courts, from your perspective?
From my perspective, I would say, like, I agree with Arlene. I think reentry is very important, and there are a lot of components missing in that field. I think as of right now, like there is no reentry specialist in the jail, which is and on my end, I've seen impact a lot of the clients and a lot of the inmates in there. So I think, yeah, I agree. The reentry is a big priority on my list.
Thanks, Nathan.
I wonder if I could just speak for a moment, Dan?
Yeah, of course, for sure.
So our part-time reentry specialist quit a couple of months ago, and Compass Health is in the process of hiring now a full-time reentry specialist. So as soon as we can get somebody hired, we should have full-time reentry services available again at the jail.
But you understand what I'm saying about how will it be structured?
Sure.
With people. Yeah, I mean, it has to be redesigned.
This is Anne.
Go ahead,
Anne. I think I want to say a couple things. Some of the programs listed on this programs needed but not in existence, we actually have some of these things in existence. So I will work with Jill to update or to modify the language. I also want to say, just in terms of the reentry position, we actually have funding where we're doubling the amount of services that we've had in the past. So once that position is hired, it will be full-time, where before it was half-time. And then third, not listed anywhere, and I actually don't know how to make it happen, but what we're noticing in many of our behavioral health programs and our housing programs is that addiction to methamphetamines has been a huge challenge for getting people out of the criminal justice system and stable in housing and stable in their behavioral health. And at this point in time, science hasn't provided us with a very effective treatment, but treatment is possible, and treatment and recovery is possible, but it is a hard road. And so I guess I would like to add that And it really would be almost appropriate for every intercept except maybe in jail. But I would like us to figure out if there was additional services we could provide that would help support people who truly want to gain recovery from a methamphetamine addiction.
You know, and because we have all these behavioral health experienced people on this committee, it would be wonderful to hear from any of you if you've heard anything about any kind of methamphetamine treatment, because I've never heard of it. And the effects of heavy meth use, long meth use, is so horrendous on individuals in terms of their ability to function that it's, if you see it, you will not get over the seeing of it.
And from a treatment standpoint, nothing new has come on to the scene yet, but I do wonder if there are some other supportive programs we could put in place that would lessen the amount of criminal justice involvement and maybe improve people's chances to get housing and access to treatment.
And if I might probe you just a teeny bit further, are we thinking like maybe additional or different or new recovery supports, possibly like community recovery supports? I'm kind of wondering where you were going with that. I was interested.
I think along the same lines. I mean, we're not scientists here that work in the treatment field in terms of developing, neuroscience interventions, but I do think that if there was a way we could provide more support in recovery in a setting that people who are truly dedicated to this effort can get the support they need, because treatment alone isn't going to be effective without significant community support.
I was on a call, it was an opioid convening from the North Sound Accountable Communities of Health the other day, and obviously that's a group specifically focused on opioids. We spent a decent amount of time talking about meth. And I guess one of the things that I take away, and when I hear you talk, it reminds me is no wrong door. So while some of those systems may be specifically focused to deal with opioids, obviously the folks are coming and they frequently have polysubstance abuse issues and polysubstance use disorders. And so no wrong door is something that we can do, not get overly focused and be able to treat everyone.
And I'd echo what Mike just said. We're seeing a lot of polydrug users, which makes treatment very difficult. You've got people that are both opioids, heroin, and methamphetamine, and that's a big part of the challenge. And that just kind of anecdotally dovetails into the increase we've seen in mental health calls, and especially mental health calls with seems like more juveniles and suicidal ideation. So going forward, obviously, I'd like to see for the sheriff's office a place where we can take some of the juveniles. Obviously, we have the crisis stabilization facility, but I don't know what the plans for the old triage center are, and there may be issues having juveniles that close to adults, but I would certainly like to see some progress for that, because again, that's a population that we've seen an increase, at least with the sheriff's office. And then as we move forward, any dedicated mental health professionals that we can have riding with our mental health deputies would be helpful, similar to what they're doing with the impact program down there in Skagit County.
Doug, can I ask you, is the increase in the youth, are you thinking you're seeing an increase in meth use among youth also?
I'm not, I'd have to go back and see if we can pull some stats on that, but right off the top of my head, I can't say that we're seeing a significant increase in the amount of youth, but obviously it's making a resurgence in our community, that's for certain. And heroin for a long time, heroin and opioids were the big issue, but meth has certainly seen a resurgence.
Thanks.
Yeah, Dan, Mike Hilly here, EMS. So yeah, this is a big deal for us. Averaging 5, 6, 7 overdoses a week, a couple of 3 deaths per month. It's epidemic, and I watch those numbers pretty close. While meth is certainly a big issue, most of all these overdoses or deaths are polydrug overdose deaths with a large fentanyl component. And I've mentioned to this group before that we tend to miss almost half, if not more, of these interventions because the patients get woken up or they get stabilized a little bit and they've had a previous bad experience in whatever ED they visited, and then they leave. And so we're just missing the opportunity to have that conversation on scene with those patients, and would love to be able to put maybe a pilot team together that would respond along with EMS to have that conversation, that maybe had a SUD type of mental health social worker expert, maybe with the EMT or medic to go out and, or the officer to work that call. And then hopefully get them over to the diversion center, at least for an initial, look, even if they decide that that's not their day to work. But this weekend, King County recorded 40 overdose deaths with, again, I think it was a given week, highest ever recorded in King County. And it's always a little bit of a thermometer of what's going on in the surrounding communities as well. So we've got an emergency here, that's been potentiated with the COVID thing. And I think going into next year, we need to look at this. I talk at Megan and I talk almost every week about this. We have some ideas, we've shot some, dream ideas off of what something might look like in the community, but in particular, the tribal community is suffering the hardest on this. And I just think we need to work on that hard this year.
Hey, Jill,
do you think that what we need is some sort of living setting where co-occurring treatment can occur and people can stay for a long time in order to get stable and sober?
I think our recovery house that will be coming online here soon will probably be our first foray into that. And I think we'll have to look closely at the outcomes and how that is effective in helping support people in recovery, especially from methamphetamines. And then if that's working, I think we probably need to figure out how to expand it if we need that.
Okay. Hey, Jill Nixon, can you go ahead and take us out of the agenda and put us back onto the gallery view? Okay, I just want to be able to see everybody. So it's 9:28, and I want to make sure that we continue on with the rest of our agenda. This is good discussion. We've identified a few subject areas here: COVID, reentry, and substance use disorder, in particular methamphetamine, but also opiate is still rearing its ugly head. I just want to give an opportunity for other folks to chime in here with other priority areas that we can be focusing on here during 2021. And just go ahead and raise your hand, Melora.
Mike, sorry, Dan, this is just in context of what's already been said. In regards to reentry, it would be extremely helpful if a reentry specialist was able to work outside of the jail as well to help make that warm handoff. That discharge planning and reentry work has been really helpful when someone's been in that position, but it's often limited to the jail location as well. And so sometimes that warm handoff isn't as smooth as we would hope. And the other piece regarding methamphetamine use, in just regards to permanent supportive housing, I would say, I don't know what the statistics are now, but roughly 15% of people in permanent supportive housing are not able to continue on with a lease and be in compliance with lease. And my professional guess would be that most of those folks are struggling with meth use, and that the property damage and the behaviors that come along with that within permanent supportive housing make it impossible for them to be in compliance with their lease. So there is also all that work that's going to getting someone housed. And then because we don't have good supports around substance use, meth specifically, often they are not successful in keeping their housing.
Thanks, Melora. That's an important point. At last count, I think the county health department counted 102 people on the city hall's front lawn I don't know to what extent some of those folks are experiencing that issue, which would make housing very complicated, if not impossible. So, okay, well, let's see. In the interest of moving things along here, it's 9:31 right now. I want to, Jill, were you able to capture some of the thoughts here?
Yes, I was.
Okay. What I'd like to do is, just in the interest of respecting all of your time, is work with my co-chair, Mike Parker, on developing some forward motion on the items that we heard discussed this morning. So that would mean, and I think of, we have NACO, which is the National Association of Counties. We have the National League of Cities. We have resources at our fingertips that we can be reaching out to other communities to see what's going on in terms of other treatment options, for example, or housing options for folks, and also what people are doing during times of COVID. And those aren't the only resources. I know we have other local resources, but I'm gonna make it incumbent upon Mike Parker and myself to provide a little bit of framework for those items, and then bring that back to the group for our February meeting, so we can continue these discussions. And of course, feel free to add to this. I know we've got a plethora of items that we're going to be going through today, including LEAD and youth and young adult. So I know, and those are absolutely priorities, and we'll be discussing those as well. Mike Parker, I put you on the spot there a little bit. Is that okay for us to do?
Sign me up.
Okay, all right. Is that okay with the group then? Is for us to do that work offline and bring it back? Okay. All right, I don't see any objections. Okay, excellent. All right, then let's go ahead and move on to our next item. This is item number 3. Jill, if you can just briefly bring the agenda back up, and then go back to the gallery once I read through here. We've got a number of different presenters. If I'm correct on this, this is the youth and young adult piece. Yeah, youth and young adult current interventions, challenges, and opportunities. So peer learning network through NACO, that's that National Association of Counties. That's the one that Ann Deacon, myself, and I don't know, like probably 30% of the people on this call are somehow associated with. And then also we are honored to have Chris Cochran here this morning from Bellingham School District to discuss things that are happening with our local Bellingham schools. So Ann, do you want to just maybe take us through a little bit on NACO and just let folks know what we're doing here with that?
Sure. We applied for a technical assistance grant called the Peer Learning Network, and we were one of 13 counties across the nation chosen to participate, and that's through the National Association of Counties. And the focus was really on reducing incarceration for people with behavioral health disorders, people who are perhaps unfairly treated due to ethnic and racial disparities. And so we have had a number of virtual meetings with colleagues throughout the state, not only to share the peer learning piece of it, share what they're doing, as well as getting some technical assistance from national experts that are provided. I think one of the things we've noticed as kind of a common theme across the nation is simply that we have a number of folks trying to figure out how to work more closely with law enforcement, whether that's through a co-responder model or alternative dispatch models, or even programs like our GRACE program, which attempts to address people who are high utilizers of criminal justice systems, 911, when in fact a more appropriate response would be much more effective. So there is a webinar next week or this week that we're going to be attending that will be addressing some of the close collaboration with police departments. But we're hoping to gain some information that will help guide us in our program development. And I would also say that, and I'll let Perry or Dan correct us, but I think we're we're near the top of the pack in terms of the activities and the programs we've developed and put in place. And I also think that's one reason why we were chosen to be part of this very elite group of counties doing this work.
Perry, you want to add anything to that?
I would second what Ann has said, just in regards to, it's been super helpful to sit in and interact with the other counties. And a lot of times, as egotistical as this sounds, that I find that Whatcom County is well forward of a lot of the discussions that they're having and programs that they're developing. I might also add that, and I'll send it to Jill, there's actually another webinar. Ann was correct, our webinar is on the 27th to sort of reconvene and do some more education with NACO. And there's actually also a webinar that's, I'm sure, available to all here that is oriented towards youth and young adult interventions. And so I'll send that information forward to Jill so that she can send it out as a link that you can sign up for. It's on the 26th from 11 o'clock to 12 o'clock. So pretty interesting stuff.
Okay. And then just before we get to Chris, I just wanted to just provide just a couple more comments real quick here, just for the group, for the benefit of the group. This committee has traditionally been the one that's really pursued upstream interventions. I think there's other members of the task force certainly that are very interested in looking at those items. We know that when a person turns 18 and if they're unfortunate enough to enter the criminal justice system, that we could have probably done some interventions prior to that. And the task force, however, is only charged with adults. And that's our mission. So we've had to deviate a little bit from that and try to look upstream a little bit. And that's really the purpose of looking at young adult incarceration prevention. That's the reason we were able to secure this peer learning. Then this is the second one. We've Ann and others have been on the first one, on the MacArthur Foundation funded one, where they sent us all over the country, to DC, to Philadelphia, to San Francisco. And we learned with other communities about where they were at. And I would agree with what Perry just mentioned, that we are ahead of the curve on a lot of these items. Doesn't mean we still don't have work to do, but we are. If you look at Indianapolis, Overland Park, Kansas, any of the other subject cities, and boy, they've got some work to do, and their problems are different than ours. So I'll kind of just end with that, and I'd like to turn it over to Chris Cochran from Bellingham Schools to talk about what's going on from his perspective.
Okay. Again, I appreciate being with you today. Is there a way that I can share my screen, or should I just talk through points? Either way is fine.
I can promote you to share screen. Just give me one moment to do that.
Okay.
Okay, you should have the ability to share your screen now.
Perfect. Thanks. There you go. Okay, so I just thought it might be easier to go through a couple of slides. Can everyone see that okay?
Yep.
Good. Okay, so again, some background as you're reading through things here. This position that I'm in as mental health coordinator for our district is a new position as of June this last year, 2020. And so in the past before that, I have worked as a school counselor for the last 7 years at Options High School. And in addition to that, worked part-time in private practice as a mental health therapist. My wife and I have a small clinic in Bellingham as therapists. And then I worked before that as elementary school counselor and other positions. And going way back, I worked in a lot of social services like Northwest Regional Council, worked at Juvie for a while, CMAR Visions, inpatient treatment, different things like that over the years. Just like all of us do, you know, figure out our path through our trajectory through career stuff. So, so in this position, I think the district had been looking for a long time at finding funding for a way to allow someone to have a really dedicated effort towards making our mental health services more intentional. And there's been a lot of our directors of teaching and learning that have had their hands on that, and mental health and wellness and those kinds of things, but it's been one of 20 things on their plate. And so the wonderful thing for me is that really this is my main focus. And so part of my job is funded through a Kaiser grant that the district has received, and also about half of it's through district funds. So that's kind of where it's coming from right now. And part of the last 6 months has just, of course, been learning and making connections, and also helping support where we're already at. So in terms of looking back and looking at, okay, what is the good work we're already doing across our district, and looking for ways to optimize that and improve that and expand those good practices, looking for all the blocks that are things that are getting in the way of those good practices, and how can I minimize those and get those out of the way for our counselors and staff. And then looking down the road into the future, what that will look like and how can we anticipate community need. And that's where these guiding values come in, looking at how do we consistently look at that equitable access across our whole district. Because in the past, there's been amazing work going on, but it's largely been, not largely, but a lot of times it's been piecemeal. And so figuring out ways to make that more consistent across the district, looking at ways to be really intentional about our continuum of services, so that we're able to look at a gaps analysis, to look from all the way from prevention to responsive services. Is there an easy flow or a warm handoff for going through that continuum if a student or a family or a staff person needs more support? How are we doing that? And then that anticipating community need in the future, are we able to do that using multiple perspectives so that we're anticipating that accurately? And then always looking at improving it and just continually getting better. We have 23 schools, so we have 14 elementary schools. And I will say that, you know, Dr. Baker, our superintendent's been around just over 10 years, I believe, and he's done, not only he, but he's headed up a lot of amazing work along with a lot of the leadership at really increasing counseling staff across our whole district. So, and I don't have stats on exactly where it was 10 or 11 years ago and where it is now, but I know that there's been a significant increase across elementary schools, whereas before it might have been one counselor spread across 2 or 3 or 4 schools. Now we have one at each of our 14 elementary schools. Our K-8 parent partnership that's in the Larrabee building has a counselor there. Our 4 middle schools have 2 each, and that's been an increase over the last several years. Our 3 large high schools have 4 counselors each. And then Options has a full-time as well. And then in large cooperation and partnership with the health department, we have 3 prevention intervention specialists, which are SUDPs, substance use dependence professionals. And those are at each of the big high schools. Bellingham and Options share one. So that makes for about 36 counselors and 3 prevention intervention specialists. So those are, I interact with a lot of other people, but generally those are the people that I'm directly supporting most of the time. I'm looking at 3 main focuses anytime I'm looking at what I'm doing in my work, and that is, how are we supporting our staff? How are we supporting our families? And how are we supporting our students? For our staff, we have a Big 4 Wellness Initiative, which is a campaign that was started in March, so almost a year ago now. And really, this was just a small group of individuals on an informal basis that were really passionate about wellness. And it grew and grew and grew until the district took it on as a campaign. And it's really those 4 areas, those 4 domains that we really want to encourage staff to grow in those areas. And what we mean by that is that, as you're aware, I'm sure teachers have a lot of professional development they have to do to keep their license, to keep up their practice, to know what they're teaching, all those things. We wanted to be able to provide professional development that has nothing to do with any professional needs, but is only for personal benefit. And so we've started providing things like yoga classes, Zumba classes, book studies, you know, things outside, or the walking groups, things like that, that they can do for personal wellness. Because as we all know, I think in the last 10 months, we've all felt a pretty big impact around how do I keep myself healthy and keep going in the process of all this. And then also trauma-informed practices. This is more of I would say, an informal initiative right now, but what we're seeing in the last 10 years, and especially the last 25 years of brain development and understanding the brain more, is that if we're trying to not only help our students learn and help students teach or help teachers teach effectively, being able to understand more about brain development and how that works and how trauma interacts with that and all those things that we talk about a lot in multiple areas of society, that all directly relates to teaching, especially when you have a kid come in without breakfast or who had a traumatic night at home or all those things that happen. So helping teachers learn more about that. And then the professional development that they do need for their teaching. How can we make sure that's really practical strategies that are going to help them with their students in terms of helping students learn how to regulate their emotions and attach? And there's a whole body of literature around attachment to school, even just helping students feel more confident and competent in school so that they feel like, hey, I know how to get help. I know how to make connections with both staff and peers. In terms of supporting families, looking at connections to their school, what we've realized real quick, and I have in this new position, and I'm sure a lot of my coworkers have known for a long time, is that most families feel more connected to their school if they're Sunnyland Elementary family than they do to the district office. So if we have something we want to, like some information we want to push out from the district office, we will usually try and do that in a format that allows Sunnyland to just put it on their website or send it out as a little part of their newsletter, because we know that families are more likely to read it because who knows what it's going to be for lunch on Wednesday, and their kid's probably going to want to know if it's hot dogs or chicken nuggets. And it's not just that anymore. We have a lot of amazing food now. But I know my kids at home always want to know what's on the menu if there's lunch is coming. But we also know if we want them to get a piece of information or we want them to be able to give information back to us, much better done through the school. So both information, relationships, and if we have services that are coming up through our family support center, things like that. Wellness resources, our communication department are pretty amazing people. It's a great team there. So I work with them a lot about mental health, especially right now in COVID, talking through, like right now, I was talking with some ladies from the health department a week or two ago, and our communications department and them are working together to look at how do we send out some information that will support families. And one of those things right now that's been going on for a while is medical providers really working on making sure that doctors, when they're meeting, pediatricians, when they're meeting with a kid, are having that conversation about mental health and suicidality that they may not have had previously. And so we're working with parents when we send out that information to families. How can we give them sentence starters or ways to start that conversation so that they're able to check in with their child as well, knowing that parents are going to know their kids way better than any of us are. And then, of course, school events and specific mental health support. And that would look like someone like me they can talk with, or their school counselor, and then myself if needed. District-wide support. I end up doing, my job is probably 80 to 90% coordination across the district and about 10 or 20% specific consult around cases that are more complicated. So each week I probably have 2 to 3 cases that I get calls about. And we also have a mobile response team, the MRT, which I'll talk about more in a minute. And so it just looks, that district-wide support is going to be not only information, but also specific support to cases. And then finally, looking at our students, and this is a couple different screens, because this is where the majority of our efforts go into, obviously. I was thinking about talking with you today and being able to be part of this team. And I know that Dan and I and a couple other people, I heard and read about upstream and some of that ideology. And I think so many systems use different words for the same term, the same ideas, right? And so we have this thing called multi-tiered systems of support, or MTSS. It's been around for a while now, and that's really important in education. It's basically that upstream idea that we're trying to get as many interventions as early as possible in the stream to help that prevention piece. So looking at the MTSS, continuum of services, looking at what's happening at different levels, elementary, middle, high, and then what community partners are we working with. So this MTSS, it's really a 3-tiered model, looking at that bottom tier, the blue base is every kid gets that. So every first grader is going to walk into their class in the morning and have a morning meeting. And that would look like social emotional learning curriculum. So that teacher is going to be working with them on whatever topic might be that day from the curriculum, but it's usually self-awareness, getting along with peers, regulating your own emotions, being able to think through self-reflection, things like that. And then tier 2 is going to be more targeted. So it could be a support group, could be checking in with a school counselor, something that's accessible to any child that needs it, but it's an additional level of support that maybe not 100% of students are going to access. And then the third level is going to be really personalized usually. So it might be, in this, a behavior plan, and this happens with academic instruction, it happens with attendance and behavioral health. So for instance, if somebody is doing literacy teaching in their class, every student's going to get literacy instruction. Then some students will need a little more, and so they'll do more wraparound instruction. And then some students, very few, probably 5% will need that top tier. So usually it's about 100% gets blue, the bottom tier, and these are just colors that were on the particular picture I grabbed, but they're often different. And then the second tier is going to be maybe that next 15% up. So 80% is fine. That bottom tier 1 is all that 80% needs. And then that next 15% might need the second tier, and that top 5% might need that third tier. So whether that's in behavior, whether that's with attendance, we try and do a kind of that progressive approach so that we're just providing the interventions that each student needs. And that response to intervention model is, in fact, RTI has actually been written into some of the more recent modifications in federal legislation for special ed, for IDEA. I know I'm kind of going through stuff quickly. Hopefully, if you have questions, feel free to interrupt, or I can answer them at the end as well. This continuum of services is really important. Looking from the ground up, not tier 1, again, we're looking at preventive support. This is our first year, this school year is the first year that we have a social emotional learning instruction, the SEL instruction, for K all the way to 12th grade. So we have been working in our K-5 schools for about 5 years now using something called Caring Schools curriculum. And basically what happens is every classroom has a morning meeting, and the teacher, like I mentioned, will give some instruction. They'll go over a lesson about something related to getting along with people, or how do you take care of yourself, those kinds of things. Now last couple of years, we moved that into 6-8 in our middle schools, and just this year we moved into high schools. So I'm really excited about that, because that's something that is just ultimately important. If we're trying to provide tier 2 and tier 3 services, it doesn't make sense to not have tier 1 there for high school students. And then the next level up would be those ongoing things like support groups that a school counselor might be providing. We also have mental health referrals to just community agencies, but we also have school-based mental health providers, which I'll talk about in a minute. And then check-ins. There's a really popular model called check-in, check-out, where if a student is struggling, let's say they have some organizational challenges or something else, a lot of times school counselors will just have them check in for 1 minute in the morning, make sure they have what they need for assignment, check out at the end of the day. Hey, did you get what you need? Do you have your stuff written down? Boom, and they can head on out to the bus. And then that responsive services, looking at suicide screening. So if we have a student, usually it would come to, we would hear from a peer or from a teacher that a student is feeling suicidal or has some thoughts around that, or maybe a teacher sees something in the writing that a kid is producing and they're concerned. And so a counselor would sit down with them, do some type of screening for suicide. And then if that turns out that it is true and there is some risk there, then we would be working with parents. If it was a significant issue and we were worried about imminent risk, right then we might call Compass MCOT, the Mobile Crisis Outreach Team, and be working with them as well. Or it could just be a behavior plan, or helping a student with something else. And then that aftercare, if there's some kind of tragedy or a crisis, our mobile response team is a group of about 30 or 40 of us across the district and across all disciplines, nurses, teachers, counselors. And really our goal is to go in if a student or a staff dies and the impact of that is such that the school really can't function. We go in And we help them process that to the point where the school can get back on its feet and start doing what it should be doing, which is learning and teaching. And it's not grief counseling per se, but it's really just debriefing. And so we think of it as concentric circles. Like if, let's say, a 4th grade student died at a particular school, we would be going into, you know, that classroom as that first concentric circle, and then working with all the 4th grade students and then other students that may have lived on that street or things like that with the staff. And we work with law enforcement as well when that happens. And then the next piece would be working with our treehouse to actually provide grief and loss work. And then when our treehouse's services start to curtail, we'd be working with mental health services to make sure that, let's say, that very small group of students and families that really were impacted who still need more support have therapists to work with. So that postvention piece and aftercare is really important. So that kind of shows you a little bit of our continuum of services. One thing that I didn't talk about specifically in the responsive part is that over the last 5 years, Steve Morse and other people developed a program with Compass and CMAR and Unity Care now that has therapists that come into the schools before COVID, of course. Now we're doing telehealth. But really what that means for us is a streamlined intake process and less of a waiting period so that our kids can get in to get a therapist when they need it instead of waiting. That's the hope. And so right now we have all of our 23 schools can access that. The one thing we're working on right now is that CMAR and Compass only take Medicaid related insurance. And so our families that have private insurance or no insurance, there's some gaps there. And so we're working on funding around that and also looking at how to work with private providers that can take private insurance. So, but it has been a great thing for us. I think I checked just the other day and we already had 68 referrals for this year go through with our just in the school-based therapists. I know that a lot of families will navigate the mental health system on their own outside of those 68, but that's just 68 that we were able to help get through in a faster fashion. This spreadsheet was something I worked on the last couple of days that's usually in my head, and I wanted to try and make it a little clearer, and that is what I've talked about already, which is these levels of prevention to things that staff are doing, things that community partners, some of the community partners we work with, what they're doing. For me, I feel like there's not going to be a magical influx of money unless you're aware of it that is going to hit us like a wave and it will solve all our problems, although we hope to keep looking for those things. But I do know that the more we can leverage out of partnerships in the community and the more we're on the same page, I think the more effective our support will be. So one of the main aspects of my job has been reaching out to WDRC, Bridget Collins, working with Compass and CMAR and all these different agencies to try and make sure that we can help them do the best work they can do, they can help us, and that we're just really aware of each other's needs and how to make sure we're doing warm handoffs with our kids. So that's what I'm working on a significant amount of the time. And then the responsive piece, and then the crisis response, which I've talked about already. I think there's just a couple other things. This is some of the curriculum that we've been using. CASEL is a national model for social emotional learning that we're using for middle schools. We're, at all levels, we're doing small groups, one-on-one check-ins, suicide screenings if we need that. And then some of our community partners, again, that I had listed in that document, but I think that's really about it. My goal as we go forward is, I think probably threefold, like I mentioned before, continually improving and looking for ways to keep things being more effective, increasing our partnerships in the community, and then just finding ways to directly support our counselors right now, because I know we know that's the best first step for our families in reaching out for help, because they're more comfortable with their home school. And so however I can support them, that's really what I'm about. And then some of the things, like I mentioned, that is just that relationships piece. We know with trauma-informed work that relationships, everything ends and begins with relationships. whether it's upstream or MTSS or response to intervention, whatever the model is, that prevention seems to be, as we all know, ounce of prevention is better than a pound of the responsive stuff. And then community collaboration and that healing power of during COVID, we've seen that with the community. So I hope that gives you an idea of kind of where we're at with our system. Again, across our whole district, our goal is just to keep getting better. Thanks for letting me share.
Thanks, Chris. Hey, Jill, can you take us back to the gallery view so we can, I just want to see faces here and see if we have questions for Chris.
Sure, thank you.
There we go. Yeah, questions for Chris or thoughts?
I'm so impressed by the program that you just described. Dan, do you remember that in our steering committee meeting talking about prevention in the school system, and it was already, or it's happening. So it's pretty terrific to hear the extent to which you've worked on this program. It's amazing.
Thanks, Arlene. Stephen?
Chris, I echo Arlene's sentiment of how impressed I am with all you've done. And I recall just a couple of years ago, we had some of the school district mental health team in, and the way you've really staffed up services is just stunning. So congratulations for all of that. I'm mindful that we're a county task force, and so much often happens in Bellingham that doesn't happen out in the counties. What kind of connections do you have with other school districts? What kind of progress is being made out there, and what sort of collaborations are going on or are contemplated for the future?
That's a good question. So I would say 3 levels. There's the informal level of just being a small county, right? So we tend to, like, I know counselors in all of the districts in the county just through working as a school counselor for years. But more specifically, that MRT, the mobile response team, we've had that in Bellingham for, I think this is the 33rd or 34th year now, but the county has never really had a mobile response team. And if you remember, it was probably 4 years ago now that the middle schooler out in Linden passed away, Violet, the 7th grade girl that died. When that occurred, several of us from the MRT here went out to Linden to help out, and that I think all the county districts realized this is a pretty significant issue. And so in the last 2 years, our MRT leadership has helped the county start an MRT program. So we have about 30-ish, maybe 35 members in the MRT for Bellingham schools. But I think by the end of, I'm thinking by a year from now, we will have about the same amount of membership for a county MRT. The great thing about that is if we have a significant event that happens, which we already had a year ago, as you're probably aware, the principal at Sunnyland was killed. And so that was the first time that the county MRT responded with us and was able to support Bellingham. We've been able to support county districts a number of times. So I think that's a big cross-pollination where we've been able to help train them because we already have the training going from 30 years. So it's pretty polished at this point. And then like the Northwest ESD, which is out of Anacortes, they support all those districts. And I'm part of a mental health consult group that has almost every district in the county. They have a mental health person. And so there's about 6 or 8 of us, and we meet monthly just to say, okay, what's going on at each of the county schools? And I think that cross-pollination and that sharing of ideas has been really important. I know all the superintendents talk with Dr. Baker, but I think being able to look at the mental health and the wellness piece has been a big deal. And I think COVID has brought that to the forefront so that all the county districts, all of us nobody has the luxury of not talking about it. So I think there's only going to be more of that. The other one last thing I would mention is that we've started a learning group. It's really just an informal group of people that are interested in trauma-informed practices. And we have some people from Western Washington University, from Whatcom Community College, a lot of people from Bellingham schools. And then we've had some other district people from the county, Ferndale, Nooksack, places that have joined as well. And it's really just whoever's interested, we want to include them. And the goal is to just keep learning about it so that we can improve our practice in schools of how are we not only serving our kids coming into school with trauma, but we know that it's kind of like English language learning. All those things you put into instruction that help English language learners, they're good for every single student. It doesn't hurt anybody. So there's nothing that's trauma informed that's, if somebody has had no trauma in their life, those are going to be helpful for them too, because it's just relationships and good practices. So that's something that's just started in the last couple of months.
Mike Parker.
Yeah, I'll make this brief. Chris, that was extremely thorough, a great presentation. And from such a system, I'm imagining that you're really capturing most kids, and maybe many that might have missed services in the past are being, I guess, caught, if you will, by your increased net. I'm remembering, as Joe Fuller mentioned, how many groups he's been a part of, that Healthy Whatcom identified youth mental health and school-based services as areas in 2018 and before to double down in. So thank you for doing that.
Mike, I think we lost you. Okay. Well, maybe he'll come back online. And in the interim, any other folks want to chime in real quick and have any questions for Chris or observations? Okay. Okay. Well, Mike, I don't know what to do, man. You look like you're frozen in time there, but I guess you should probably think about moving on. Chris, I just wanted to say thank you so much for the presentation this morning. It's really important that we have the context. Mike says his computer died. That's what happened. So maybe he'll chime in with a different device around his phone here in a minute. So, but we're gonna go ahead and move on. But Chris, thank you so much. You're a very welcome addition to this team. I think it's important that we have the context of what happens to folks before they become adults, you know, and when they're in our school systems. And then Mike he has his question is, what are the gaps that are left? He's asking you, Chris.
Mm-hmm. So and that was one of the things, well, several things that I'm sure I'll be learning with this team. So one of the exciting things, one of the first things I did was connect with the GRACE program and BPD. I met with Officer Sarad, with Laura, as well as with our district resource officer. And so I think one of the things there that my concerns about gaps is that I know that just because school's not in session doesn't mean that students don't have needs. So if Whatcom County Sheriff's Office or BPD is out, and let's say it's Saturday and there's a domestic dispute or whatever's happening, let's say 8 o'clock on a Saturday night, and there's an 11th grader who happens to go to Squalicum or Bellingham High School, they have a significant event that happens. It is usually the case that on Monday we will have no idea what happened. And I don't want to make it so that we have to know what happens. I think people should be able to have privacy on some level, but I also think it could be really helpful. There's a lot of times we have students that go away for inpatient treatment and they will come back, and sometimes we're not aware of how to support them when they come back for reentry. So one of our goals is to work more closely with those programs so that we can be supporting across systems like that. And Officer Leland has been wonderful to work with that way. So our goal is to, I would say, in terms of gaps, I think the gaps are between systems, and it just takes a lot of intentional effort and time to make sure we're talking together. So that's I would say my main goal is, you know, kids and families are engaged with mental health providers, medical providers, law enforcement, and we know that all those things happen all at the same time, right? So we have pretty good relationships with probation officers, and that's been hugely helpful. My hope is to keep working with law enforcement and mental health providers to bridge those gaps.
Thanks. Perry?
Yeah, just a quick follow-up, and I know that Chris, if anybody is really knowledgeable about this as well, that it's always struck me because we talked about this concept of an event happening for a student and the school being informed of that, and I happen to agree with the direction Chris was going. One of the events being involvement with law enforcement, which really is public domain. And the other being involvement, when you mention inpatient treatment, obviously is protected health information, and so gets a little bit more difficult, but a really, I think, important place to maybe initially look at because of confidentiality and, and those kinds of things is really the law enforcement involvement. That just being informed that there was contact or something of that nature and that it was, that it impacted the youth. I think that makes all the sense in the world, and that would be a far easier connection to make than the latter, being obviously the private health information without a release of information. And, all those things, Chris. Thanks so much.
Yeah, thanks.
Great. Other thoughts? Other questions? Okay.
I have
Heather,
a
go ahead.
question.
Yeah, go ahead.
Hi. Thank you, Chris, so much for that presentation. It's so illuminating and really amazing to know what's happening in our schools, and it's a lot of amazing work. And I'm sorry if you touched on this. I have an 8-month-old, so putting her down for a nap and listening at the same time. I have seen some data around school discipline and racial equity, and I'm wondering about if there's any way that you guys are reporting on that. I think there's like a state website that just reports, but is there a local source where we can better understand disparities in how we're disciplining and suspending based on races?
That's a great question. I'm not sure if there's a local source for public information on that. I can tell you that, so Options is unique in that it's smaller, right? It's about 200 students as opposed to 1,200. And so before we had a vice principal, I was a counselor, vice principal, testing court, all those hats, right? So I ended up dealing with discipline a lot. And I can tell you that I know in July of 2019, the state radically changed some of the rules around discipline and those guiding principles. And so I know that there's not a month that goes by that principals aren't meeting about those things. And I know even before the state made those changes around some racial disparities and other disparities that happen in discipline, I would say Bellingham schools, we've been talking about that ever since I've been here for 7 years. So I think that's probably been the guiding focus of our discipline practices and policies. I can only speak to the last 6 or 7 years that I've been around, but before the state ever made those changes, we've been working on those under Dr. Baker. So I don't have specific stats, but I would say that we do a progressive discipline model, which is the first time something happens, it's really down. And then the second, once it becomes more of a trend, then we're looking at, okay, how do we help address this as a trend? Or of course, if it presents risk to the whole population in the school, then there's a model called the threat assessment model from Salem-Keizer School District in Oregon. It's kind of the dominant model, at least in the Western United States, as that we use, as well as I think every other district, I think in Washington and for sure Oregon. But that's really looking at it. That model focuses on, and that's really only if a student, let's say, made a direct threat to somebody or something like that. Really, that's looking at, instead of just responding in a punitive way, we look around like a case manager would or a mental health person and look at what are the issues around that, what is the support that's already in place and the factors that might be causing more risk, and what can we put in place for, let's say that student is out of school for a half day or a full day or whatever. When they come back to school, how do we support them with reentry? And then how do we work with them? Of course, the goal is, right, to get them back on track. So they're feeling successful and they're experiencing success in school. So that threat response model and threat assessment model is really on the upper end of the echelon for types of behaviors that would prevent an actual risk to other people in the school. But in terms of all of discipline, I think every principal I can think of at all the high schools that I've worked with is really focused on looking at that kid in particular and thinking, okay, so what do I think the reason for this behavior was versus just being reactive, and then trying to figure out ways to take a relational approach to it. So I mean, I've worked in a couple other districts, larger ones in Oregon, and my experience at Bellingham, the culture here has been very responsive to students' needs, and in that they were already working on that before the state made changes. So to answer your question, stats, I don't know if we have local stats. I'm sure we could get them. But my experience has been that working both with Bellingham Police Department, with our resource officer, and with the administrators, which is usually vice principals doing that work, are really responsive and usually really student-centered. So.
Excellent. Okay.
Thank you. I have one more follow-up question, if that's okay.
Of course, yeah.
Well, slightly different, but I think I heard you say that one of the gaps is something might happen to a kiddo over the weekend. There might be an experience with law enforcement or some sort of family trauma, and you're not always aware. And I thought at one point we had talked about some notification program where a police officer could let somebody like you know that a kiddo had an incident. They might not need to give you any details, but just in an effort to like, let's wrap some support and love around this child because we don't know, you know, it's like an extra care day. I don't know if that's happening or if that could be happening more.
And I don't have a specific answer on, well, I would say I'm not aware of a formal channel that happens through. I think one of the hopes is that with someone having a position like mine, where it's kind of a central connection piece, that would be more the case. And so that's what our goal is, right? Is to be able to say, let's say an officer makes a contact, they're able to talk with Officer Leland, who's our resource officer, and then he can connect with myself or someone else similar to me. And then I would be contacting that school counselor and saying, hey, you know, we want to make sure that student feels they still have their privacy and that they can come back into school and not have to relive any of this. But can you just be checking in with that kid and make sure that they have what they need this week? And if they need any support, let me know. Like say, for example, you know, usually when those things happen, something's been working itself to a head for a while. So if that means we need to get them connected with mental health services, we can do that. We want to get whatever's done, whatever's needed. We want to get that done as fast as possible.
Heather, the program that you're talking about is located in Colorado. When I was there for our Children's Funding Institute, I went a couple days early and I went and talked with the district attorney's office. I was just trying to look for the name of the program. I couldn't find it. I can send it to you. We did have that the folks from that program talk to us it was a conference call about a year ago, and Byron Mannering had some serious issues with the program because there were some oh boy, I'm not going to get the language right here. There was some it was not
concerns, right?
What's that?
I'm sorry, Dan, but weren't there like some serious privacy concerns?
That was the primary concern, right? It was privacy concerns, even though, as was mentioned, it's a public record. There were some like secondary trauma concerns around other students finding out about the situation and that, you know, causing some issues. Mm-hmm. I think we need to maybe rethink that a little bit and maybe revisit that program. I'd love to get Chris's opinion as to, you know, maybe just take a second look at that. I think Byron's worked with kids for his whole career. So I, absolutely respect where he's coming from. And we don't want to introduce a secondary trauma situation. So, yeah, but I do think that there is that gap. And I think that we could look at that and maybe, to Heather's point, maybe really just maybe rethink that. Maybe we do something differently here in Bellingham and Whatcom County. Okay, so it is 10:19. We've had really good discussion. I'm going to go ahead and table 2 items. So I want to give Melora an opportunity without the pressure of time, so she doesn't have to rush through her lead presentation. I'd like to table the items that are legislative priorities. They're in your packet, and I do hope that you're able to take a look at those items, House Bill 1590 and House Bill 1406, both of which are now RCWs, or they're codified in Washington state law. Let's talk about those in February. I think we still have a little bit of time with both of them, but let's go ahead and give Melora some time here to talk to us about LEAD program. Really exciting new program, and just so glad to have you on the call today, Melora. Go ahead.
Thanks, Dan. And thanks, Chris, for that presentation. That was really great to hear. So I know many of you on the call, but Melora Christensen, I currently the Grace and Lead Program Manager. Those are both contracts facilitated through the Whatcom County Health Department and the Prosecuting Attorney's Office. Little about me, I'm a clinical social worker and have been working in Whatcom for the past 10 years. And before doing this work, I was in permanent supportive housing at Catholic Community Services and ran Francis Place and the Scattered Site program there. And so I've been with Grace and Lead now for just a little under 2 years. So Jill, if you are able to give me the ability to share my screen, I'm not going to do that right away, but I would like to show you our eligibility criteria. And I'm going to give a brief overview, and then I can get into the weeds on specifics of operations, but I would really like to hear what questions the committee has for me. So the LEAD program launched officially in Whatcom County in September of 2020. It's very exciting. That's a staff of 6, so 5 intensive case managers, each carrying a caseload of 15 to 20 across the county, and a lead supervisor. That is funded through a Department of Justice grant and a Healthcare Authority grant through Washington State. So we've been up and running for 4 months. We are currently already serving over 50 individuals across the county. Half of those are already enrolled and in the program. The other half, about 25, are receiving outreach from our case managers, and we would expect them to be enrolled in the next couple months. We've received 130 referrals since we started, just to give you an idea of how well the program is already known about. And most of those referrals right now have come from our law enforcement partners, specifically the Sheriff's Department and Bellingham Police Department. But we also have had a lot of partnership in the last month from Ferndale Police Department and Nooksack and Blaine. So we would expect those referrals to also start coming from those smaller police departments. We're also taking referrals from community partners. So we've received referrals from the Opportunity Council, the Homeless Outreach Team, from Lighthouse Mission, from Catholic Community Services. Trying to think where else. But the word is getting out slowly that that is also an option. And out of those referrals that we've processed, and I'll go into what that looks like. We've had to return 21 of the referrals that we've already gone through. So, and this is, I think, indicative of the fact that it's a new program to the community and people are starting to figure out what the eligibility criteria is and how that referral process works. So I'm going to share my screen. And so this document is our lead eligibility criteria. And this is a draft. It is very close to being finalized and will be reviewed by our policy committee this Thursday. Once it is, I'm happy to send the final document. Dan, I could send it to you if you wanted to have it as a copy. It just has not yet been finalized. It's very close. So lead folks are coming to us because they are known to law enforcement due to frequent contacts or for committing low-level crimes. And so we have examples of some of these crimes. These low-level law violations are stemming from behavioral health, mental substance use disorders, extreme poverty, and we're looking at law violations that are within the last 24 months. So if someone had law violations 3 to 4 years back, but not since then, they wouldn't meet criteria. Some examples of the eligible drug crimes. And this will probably change a little bit. We're working with law enforcement closely on the eligibility around drug crimes. And then, and please, if anyone has questions, please feel free to jump in. And then examples of eligible violations. So this is not an exhaustive list, but trespasses, unlawful bus contact, misdemeanors, theft, obstructing an officer, prostitution, active warrant. So looking again at any charges that we know are coming from other extenuating circumstances. So LEAD, as we know it in Seattle, or in, when it first started, was an arrest diversion program where officers could divert in the moment. You know, I can arrest you right now, or I can call a case manager and get you connected. The Seattle programs also added a social contact referral, and that is how Whatcom County chose to roll out our program. So really, you can think of social contact referrals as a proactive response. Law enforcement and the community knows who would benefit from the LEAD program. And so we're not waiting for them to commit another crime in order to get into the program. We're asking that their names be brought forward, and we do that outreach and connection so that we can engage sooner than later. So social contact referrals can occur proactively in response to an arrest or at any other point of contact based on officer discretion. Again, social contact referrals come from law enforcement agencies in Whatcom County and community partners. Before processing the referral, we do a criminal history check. This is done by the Whatcom County Prosecuting Attorney's Office and the Bellingham City Attorney's Office. We're looking for predatory behavior, and we want to make sure that LEAD eligibility requirement of recent police contact or law violations, that meets our criteria. That information is then taken to an operational work group, and the operational work group is where we go through our referrals. And currently, those meetings happen every 2 weeks. And it's a community-based group. We have representatives from the Sheriff's Department, Bellingham Police Department, Prosecuting Attorney's Office, the City Attorney's Office, Public Defender's Office, Lummi Nation Police Department, Ferndale Police Department, Blaine Police Department, Nooksack Tribal Police, Sumas Police Department, Everson Police Department, Linden Police Department, representatives from the program. So all of the LEAD intensive case managers attend the operational work groups, as well as our contract manager from the Prosecuting Attorney's Office. So we take that information and we are able to determine if they meet that eligibility criteria, and then have additional context. What's been going on for this person? What does law enforcement know about them? What did the community partner, why do they think they would benefit from LEAD? We do have some disqualifying convictions at this time. So on the left here, you can see 5 years since conviction of. And so if any of these violations had happened in the past 5 years, they would be disqualified. And then not to be considered on the right, these are other items that would make someone not eligible for the program. You see gang affiliation on not to be considered. Of course, that is something that the operational work group would have a pretty in-depth discussion about in order to determine if, because we understand that that could be that is a potential for bias right there, that someone could say, this is gang related. So we would dig into that in the operational work group. And then we're also looking for issues around violence, and if this person would pose a danger to the community, a danger to case management personnel or LEAD clients or the program. And then we have some additional considerations. We would really look into if we see a pattern of predatory behavior, trying to figure out if that is the case or if there is additional information that would make that person eligible. Have they been a LEAD before? Will this person benefit from the LEAD program? And right now we are also pending ineligible crimes are presumed to be tabled unless law enforcement believes providing lead services to the individual will protect the community. So again, in these referral conversations, we're having really in-depth conversations with both prosecutors, public defenders, and law enforcement. When additional information on a referral is provided, the operational work group has the option to make an exception to the eligibility criteria, but a consensus vote is required. And so we do have the ability, when someone does not meet our criteria, if there is additional information, then we can explore that, and we would ask the group if they are in favor of moving forward with enrollment based on that information, and we'd be looking for a consensus vote in that situation. The restrictions, other than the disqualifying criteria that I went over, is that an individual cannot be enrolled in lead and grace at the same time. Intensive case management could be transferred, and that would be done on a case-by-case basis. We've already actually had some success in doing that. And right now, an individual cannot be enrolled in lead and a specialty court at the same time. Individuals can be referred to lead if they are exiting drug court or mental health court. Again, if the drug court and mental health court program managers felt there was additional information about that individual, we could look into making an exception to that eligibility criteria on a case-by-case basis. And the other restriction is that if someone is sent to prison for more than 1 year and 1 day, that would disqualify them, but they could re-enter the program after returning to the community. And then the eligibility criteria, this is just talking again about how we would process an exception. So we would require that a consensus vote would happen in order for someone to meet that exception. So that is how we are currently doing referrals. Mike?
Thank you so much. I think you shine some light on an area of great interest, and we had heard about some of the early wins, but there were questions about how does somebody get in. So thank you for addressing that. You talked a little bit about what a normal process looks like, and that you've had to turn some folks down. And it seems like you're tracking to some degree. So as you know, the Incarceration Prevention Reduction Task Force cares deeply about racial equity. And we are starting to ask questions and trying to figure out how do we navigate that. What is your group doing in terms of capturing aspects of individuals that both you accept into the program and ones you turn down? And could you comment on that? Did that weigh in on your decision-making and your process?
Yeah, thanks, Mike. So, you know, the history of LEAD has always had a racial equity lens to it. And it's something that here in Whatcom County, we are committed to making sure that we are bringing that into our conversation about how referrals are coming to us, how they're being processed, how they're being denied, and then also, of course, how data is being captured. And so, as you know, when you launch a program, there's lots of moving parts and things have been hectic over the past year. But our management team, which is really focusing on operations, we are spending at least, 4 hours a month is dedicated to our racial equity development for the program and making sure that we are inserting that into our policies. So although we are still early in being able to provide good information back, here is how we do this, it is on the top of our list to figure out how to integrate this into all of our policies and our procedures. At the base level, we are capturing all that data, and then we are also sharing these commitments and priorities to our partners. So the operational work group, which is a very diverse group of individuals, we are also sharing that information back with them and letting them know the priorities of the program. So in short, Mike, we will have more to report on this in the next year. We are also, as a management team and the program, looking at tangible ways in which we can analyze our program to make sure that we are asking the hard questions, and even as much as, how do we operate here in the office? What are our hiring practices? How do we capture data? And so in the next year, this is going to be a big priority, as well as continuing to launch the program, but it's at the top of our priority list.
Great, thank you.
Yeah.
Other questions for Melora? Okay. I'm noting that we're just over time here, by a few minutes. I want to respect folks' time, but I do want to thank the presenters today, Melora and Chris. These are important programs, important work that's going on in the community, and I think it's worth the time to take and kind of sift through it, so this community can really understand the work that's being done, not just for context, but also for moving forward. So I want to wrap things up here. I assume everyone's got a busy day ahead of them. The two items that we're going to table for next month are the GARE, the Government Alliance for Racial Equity, that Mike's going to be presenting on. That tool will be used in this committee to make decisions. It's to his point that was just made there. How do we integrate this into our thinking and on our policy recommendations to our task force and ultimately to the county council? And the other item was the legislative priorities. And then we can talk about those next time. Please do take a moment to research 1406 and 1590 so we're on the same page. There's another bill that I don't know if it has a number, and Deacon might know. It's the 988 bill. It's suicide prevention. I think that's germane to what we've talked about, and certainly when we're talking about with any age group, but certainly with kids as well. Okay, well, are there any other closing thoughts here for the good of the order? Okay, seeing none, thank you so much for taking time today. I hope you all have a nice day. It's looking like the sun's going to try to break through. We'll see if we get lucky today. But otherwise, have a good rest of your week, and we'll talk in a month. Heather, did you have something to say?
I'm so sorry. Are you trying to close the meeting, Dan?
Yeah, I think I am.
Are you asking just for general, any closing thoughts?
Yes, ma'am. Please go ahead.
I know people are probably antsy to leave, and I am the worst at the last minute things, but as a community member on this committee, I feel like I would be remiss if I didn't mention Camp 210 and some of the people that, at least the chatter I see on Nextdoor and the kinds of things I'm hearing from colleagues, particularly in the business community. It seems that there's a segment of our homeless population that is very challenging to serve. And we've all, heard about Seattle is dying and probably watched it, and we all have our criticisms of it. But I do think that there are, for some of our homeless, an underlying condition is addiction and untreated behavioral health. And so I bring this to this committee because I think it's really important. And I don't have solutions. Otherwise, I'd wave a magic wand and probably be a millionaire. But I just think it's really important to say something to you all today, and maybe there's a conversation. But otherwise, I just think we should all be aware and know that there are some people that slip through our cracks for some reasons.
Absolutely. Thank you, Heather, for sharing that. That's absolutely spot on. Yeah, absolutely. And I think everyone's very hopeful that folks can get shelter and housing and treatment and interventions for folks that are out there. They've been out there for quite some time now. It's been months, and I share the concern. I think everyone does. So
it's connected to our priorities. When we talked about our priorities, the goals we have for care of our community are not accomplishable if those people don't have places to live. So we have to be pushing on that too.
Agreed. Any other thoughts on that item? Okay. All right. I don't want to rush us out of here, but I know that other folks have other obligations, and we're over by about 10 minutes now. So thanks, Heather, for bringing that up. I appreciate it. And thanks for Arlene for sharing your thoughts on that as well. We have a meeting in a month. Mike, Parker, and I will meet offline to discuss some of the topics that were brought up as priorities, and we'll be bringing those in advance to you. I'm hoping we can get those items out a couple of weeks in advance so that we have some time to chew things over and provide further thought on those items. And I think we're probably we should bring Camp 210 up in that next meeting as well. Unsheltered individuals, I think, needs to be part of our conversation. So point very well taken. All right, unless there's anything else, I'm going to go ahead and adjourn the meeting. Okay, any further thoughts? Okay, well, thank you very much for taking time today. Appreciate it. Have a good rest of your day.